시청자 여러분 안녕하세요.
Ladies and gentlemen, greetings. This is Prosthodontics on Friday Live, which addresses different steps of implant treatment and its side effects. Today we're going to listen about the clinical meaning of short implant with Dr. Kim Gi-sung of Namsang Dental Clinic. Thank you for coming all the way to Prosthodontics on Friday despite your busy schedule. As of late, a lot of dentists prefer short implants, and I believe a lot of people will look forward to your lecture. I have high expectations as well. Before we begin today's lecture, can you briefly explain about your lecture? A lot of attention is gained on the short implant, and many people have different opinions. I would like to talk about how short implant is used at my dental clinic and the clinical results that I have achieved. I'm going to talk about how short implants should be placed. Thank you. After listening to you speak, I look forward to your lecture even more. For those of you watching from dental site, you can communicate real time via the chat, leave your questions, have them answered, and through a lucky draw, Starbucks coffee coupon will be sent. Best question will be chosen and 3 Starbucks coffee coupons will be sent. Learn about short implants and win your Americano coupons. I look forward to your keen interest, and let us begin Dr. Kim Gi-sung's lecture. I'm Dr. Kim Gi-sung. Today I'm going to talk about the clinical meaning of short implant. When you look at different lectures on short implant, it addresses why, when, where, and how short implants can be used, and how it should be placed. Skipping a couple of stages, I want to talk about whether short implant is absolutely necessary. For me, it is. It can be utilized in various cases. In cases where it is anatomically challenging, such as proximity to mandibular nerve or in the case of the upper, proximity to sinus. Short implants are absolutely mandatory in these cases. There are many lectures and studies on short implant. At first, people looked at definition of short implant. I want to skip those areas and I want to talk about how I use short implants in my clinical practice. I primarily use Osstem's short implant. In Osstem, short implant is defined as implant below 6 millimeters. Implants with different connections. There are different specifications for short implants as well. There's also extra short implants in the market. There's bevel on top and micro etching is done around that RA value and surface roughness is reduced so that it can be placed within gingiva. These are referred to as extra short implants. Personally, I use short implants very frequently in my clinical practice. What you need to be cautious about is that compared with the other implant connection, the connection is shorter for short implants. Because the implant length is shorter, the internal thread length is shortened, therefore 5.5 millimeter is secured. Although it may be a short implant, you can use different abutments such as lead abutment or transfer abutment, and there's about 0.2 millimeter of gap. And that's how it's connected. There's a bit of clinical issue here. If you place Osstem implant and use abutment from another company, then there can be issues because of this. There can be an issue because the connection area is shorter. abutment screw length is not compatible. This is a product from another company. The bottom part can be punctured or problems can occur. There can be issues with implant screw connection as well. Therefore, in relation to short implant, you need to use original product. In order to utilize Osstem's short implant very well, special drills are necessary. 5, 6. In addition to basic kit, special drills need to be used to place the implant. These need to be considered. In order to place a short implant safely, a special kit is necessary. 485 kit from Osstem. The name stems from the fact that it can be used to place implants ranging from 4 mm to 8.5 mm. My favorite kit is 1485 kit. I use one guide surgery for all implant placement. Especially in the case of short implant, it can be anatomically challenging. Therefore, in order to place implants in a safe manner, guide surgery is imperative. 1485 kit is really perfect for guided surgery. There are different kits available from Osstem, from one guide kit to 1485 kit. Today, these three kits can be utilized well for placing short implants, especially in the case of 1485 kit. The blade of the drill, there's no wide dimension, so there's less possibility of inferior alveolar nerve being damaged. The 485 kit, it's a kit for mandibular cases where it's close with inferior alveolar nerve. Osstem's short implants can be placed using this kit. The round form of 1485 kit stems from one cast kit. The one cast kit is designed to prevent sinus membrane perforation. Such concept is utilized here. One cast kit is straight drill, and 1485 kit has round tip to prevent damage to the inferior alveolar nerve. I think Professor Cho Young-suk contributed to the development of this kit. I really like 5 mm diameter short implants. 5 by 6 mm implant is to be buried in the bone. 5.5 and 5.4 are like this. The total length of the three implants are 6.2 mm. The bevel area is either 1.2 mm or 2.2 mm. As shown, in the gingival area, it is micro-etched. The design was that the surface with lower roughness should be placed within the gingiva. The basic concept is that all implant surface needs to be buried in the bone. These implants should be placed within bone, and I think ultimately it can have good impact. Let's take a look at clinical cases. This is a case from my peer whom I really look up to. I really learned a lot from this person. This is a clinical case done by this person. In number 35, 5 by 5 short implant is placed, and in the upper, in number 26, 5 by 4 implant is placed. It may be controversial when we talk about implant to crown ratio or crown to implant ratio. The short implant itself, crown to implant ratio is quite unfavorable. Therefore, a lot of people think there can be mechanical and biologic problems. But if you look at this clinical case, the implant is short and the crown is long, but for a long time it has been functioning. If you look over here, it has been 7 years and 9 months in the lower and over 5 years in the upper. The long-term data is continuing to be accumulated. The patient told me that the patient does not have any issue with chewing food. This surgery was done by Dr. Cho Young-suk, and the patient is himself. In number 37, based on my understanding, he placed this implant using a mirror. Although there's abundant bone, The reason why he placed the short implant is because he had belief in it. I use a lot of short implants, but I believe the person who loves a short implant most of all is Dr. Cho Young-sop. He has placed this implant within his own mouth and is checking long-term data, and I think this really shows that short implants are really good. If you look at my clinical case, if it is close to inferior alveolar nerve, if you use short implant, although it may be a risky area, you can use appropriate length implant and provide prosthesis to the patient. This is a more recent case, but you can see that stable results are continuing. When you look at the crown to implant ratio, it's quite unfavorable, but if you look at my clinical practice up until now, I have not experienced any major issues. If it is placed accurately, I think it can be a very effective implant. Today, what I want to talk about is not whether short implants can be used clinically and whether they are useful. The premise of my lecture is that short implants are useful and that they can be applied in clinical practice. I want to talk about how to place these implants accurately, especially in the cases with anatomical limitations. For instance, it can be too close to the inferior alveolar nerve, or it can be too close with the sinus. In this case, I believe one guide surgery is necessary. You use one guide kit, 5 by 6 millimeter implant can be placed easily following the sequence. One cast kit can be used instead of one guide kit because one cast kit does not have wide dimension and you can drill safely. As mentioned, 1485 kit, especially in the lower, you can use a very short drill sequence to place the implant effectively. Can I ask you a question in the middle? Sure. In general, considering the biomechanical area and bound to implant contact, the implant length and surface area contribute significantly to osseointegration of implant and stress distribution. You have talked that clinically speaking, short implants are fine, but I think some people still may feel uncertainty, especially those who have been placing implants since a long time ago. In order to address their uncertainty, can you give a word of advice for them? The implants that we used to use in the past, we used to place very long implants very close to the nerve canal. In the past, people talked about how you need to place implants with at least 10 millimeter. People placed 13 millimeter and 15 millimeter implants as well. You place longer in the upper. I do not believe the length of the implant leads to more favorable stress distribution because stress distribution factor is focused on the upper third of the cortical bone. Design-wise, short implants will not be unfavorable in terms of stress distribution. There's the problem of reduced BIC. Compared with machined surface, there has been a lot of developments in terms of surface. Osstem really prides itself in BA surface and SOI surface. The surface area has been improved and BIC contact ratio has been improved as well. Using larger diameter short implants, I think it could function well. I went to Paris and listened to Professor Thomas Albrechtsen at the EAO conference. When I was in Professor Albrechtsen's department in 1996, at the time, the professor emphasized a smooth surface. But about 5 years ago, when I went to EAO in Paris, he talked about the transition and advancement of implants. He talked about smooth surface and rough surface. He talked how people used to place a smooth surface in the past, but these days he is not worried even if a 6 millimeter implant is placed because of the changes with rough surface. The surface area has been widened and a lot of improvements have been made. Osseointegration occurs much quicker. I think that's why we can rest easy even if we place shorter implants. I want to give you an example. Rough surface is the same as having a solid foundation, and smooth surface not so much. If you have a solid foundation, then it will not be a major problem if the length of the implant becomes shortened. That's my personal opinion.
그게 조금 이제 짧아져도 크게 문제가 없는 게 아닌가 이런 개인적인 생각을 해봅니다. 해봤습니다.
I think it is deeply related to the advancement companies have made with the implanted surface. I agree.
그러면 우리 저기
If you look at the chat screen, a lot of questions have been raised. So let's check the chat screen briefly.
가겠습니다. 여기 채팅창에 보시면
Good doctor.
오늘 검요보철 본방
I'm so happy to watch Prosthodontics on Friday live today. I look forward to your lecture.
오늘 또 기대됩니다. 좋은 강의.
TS, I look forward to today's lecture. Solgi, I look forward to your wonderful lecture, Dr. Kim Gi-sung. There's a question raised by ID today. Based on my understanding, there's no long-term data for 4mm short implants. In the case of a lower posterior area with a residual bone height of 5 to 6mm, is it better to place 4mm short implant? Or is it better to do 1-2mm vertical augmentation and place a 6mm implant? Which do you think is a better option? The amount of bone is really limited. I believe there's a bit of a 4mm long-term data with Straumann. It has a SS implant and standard abutment data. In Korea, I don't think there's any data. I myself don't have long-term data for 5x4mm implant. I'm a prosthodontist, and when there's only 6mm of residual bone, I've heard that the results of doing vertical augmentation are not really good, and it's not easy to do so, so I do not agree with a vertical bone augmentation because I'm a prosthodontist. 5x4mm implant would be better in this case. Maxillo-oral surgeons, they would prefer doing bone graft. But with time, even if you do bone graft, they can be absorbed. About half of it does. As a prosthodontist, I think it is better to do without such process. TS. If you use a short implant, I think the bone-to-implant contact will be reduced. Do you recommend using wide implant when you use short implant, or would it be okay to use regular size long-term? For short implant, I think the diameter should be wide. In terms of contact surface and in terms of what is allowed by the government, you can place up to 5x6mm implant. In regular diameter, 6mm short implant is not approved. There's Astra implant, regular size. I think there's potential there, but we need to use a wide implant if you are to use a short implant because of regulation. Short implants are widely used in the posterior area, therefore you need to choose diameter of 5mm or more. When we drill regular to wide, people say you need to be cautious of drilling because there's a higher possibility of failure with wider diameter because of the damage caused by drilling, and a lot of people say you need to take a lot of precautions. Vanilla ice cream, this is a topic I've been interested in. I look forward to your lecture, Dr. Kim. Barista. When you use short implants, do you use the same implant placement strategy, or do you increase the number of implants to be placed? I'm sure a lot of people are interested in this topic, for instance, in the upper. In the case where it requires 6 to 8 regular size implants, if you are to use short implants, would you use 10 instead? If you look at Osstem's catalog, it is recommended that you splint it personally. I believe you do not need to increase the number of implants just because you're placing short implants. If you're placing 5 by 6 millimeter implant, you can just use the treatment plan you normally use. At times, I use Pontic to skip one. I regard a short implant as the same as general implant. I think you need to look at the long-term data as well. If you use the same number of implants for short implants as well as regular implants, what will be the difference in terms of success rate? I'm going to address the success rate in the end. So we skip to the end. I think this ID is Hatgai, Hatgui 12. In TS3 extra short implant, in the implanted top area, the bevel, where it becomes narrower by 1 or 2 millimeters, why is it rough surface instead of machined surface? I think this was determined under the discussion with clinicians in development stage. I think this is a very important question. The products from Dentium, the bevel area is machined surface. It's nice and shiny. In Osstem, following the original development purpose, if this area is positioned within gingiva, it could be machine surface, but it is under the assumption that the implant will go into the bone. The machined surface, the rough surface, it's not as rough as originally intended, but it may encourage bone formation. Therefore, in development stage, intentionally it was made rough surface. Some people think a machined surface is better, but if you place it deeper, you need to consider bone formation, and that is why this design came to be. When I was in Sweden, when I looked at the histological studies that I've done, when you place implant and wait for bone formation, endosteal bone formation occurs first, and then periosteal bone formation occurs. The bone formation is made around the cervical area of the implant. In order for such bone formation to occur compared with a machined surface, it is better when it is rough surface. I think there are pros and cons clinically in terms of plaque maintenance. Machined surface may be better, but for new bone formation, rough surface would be better. I think new bone formation has more plus. I agree. Let's entertain one more question and then carry on with your lecture. At the very end, we'll continue with the Q&A session. Kims, if you place a short implant, comparatively implant crown length becomes elongated. Crown and implant body length ratio becomes unfavorable. Will there be any complications? It's the question that I've raised. Mechanically, it can be unfavorably. Cantilever force is increased and it could be unfavorable, but this is related to implant position as well. If you place it in good position and get good axial load, then it will not lead to major problems. I personally don't get the sense that there are more complications just because you place a short implant. In terms of prosthesis for short type implants, I use ER type with screw holes so that periodic retightening can be done because the primary problem related to short implants is associated with the screw loosening. I don't experience any biologic complications. Do you think it would be wise to caution the patient about food? We always tell implant patients to be aware of eating tough food, but especially for patients with short implants, maybe we need to caution the patient about eating dried squid or other tough food. Personally, I don't give any special precautions. I have trust in it. That's interesting. I think you have very strong belief on short implants. I would be worried and I would tell the patients to be aware of dry and tough food. So this would be the end of questions for now. After you do your lecture, we'll have Q&A session to address the rest of the questions. Dear viewers, thank you for the lovely comments and your questions. I look forward to your participation, and among those who have raised questions, we will do a draw and send coffee coupons. Please carry on with your lecture. Let me share with you my clinical case. As mentioned, I always use one guide surgery. I always use a digital guided surgery for all clinical cases. There are various kits that can be used for one guide surgery, and I'm going to show you different cases where I've used these kits. I've used one guide kit to place a short implant in the upper. I really like doing sinus lift using one cast kit, but in order to do sinus lift, the sinus needs to be clean. But as you can see, for some reason, there are lesions within the sinus and some haziness. If you have a sufficient amount of vertical space, I think it would be better to use short implant, and this case falls under that category. There's about 7.7 millimeter of vertical bone. This allows for short implant, therefore I used one guide kit here. In general, in one guide kit, the drills for 3.5 by 6 millimeter are not readily available. If you like short implants, you need to buy these drills on the top. The drill sequence is as shown. You do tissue punch. This is a flapless surgery. After initial drill, 3.5 by 6 millimeter one guide drill and 4.5 by 6 millimeter one guide drill is used. You reduce the RPM, and then I placed a 5 by 6 millimeter implant. Personally, my favorite implant surface is Osstem TS soy surface. Osseointegration occurs within a very short period of time, and BIC is very favorable. 5 by 6 millimeter implant is placed flapless with one guide, and the healing abutment has been connected. The case that I've shown you, these cases that I'm showing you today are recent cases. I've waited for the site to heal after about 6 weeks. I measured ISQ value and started loading. You can see that the implant has been placed up to the inferior margin of the sinus. Sinus membrane was not perforated, therefore, implant has been osseointegrated regardless of the lesion within the sinus. Let me show you a second case. One cast kit instead of one guide kit was used to place the implant in the upper. The reason why I used one cast kit instead of one guide was because in the one guide kit, if you look at the series of wide drills, after 3.5, it becomes 4.5. The patient case, if you look over here, it's number 27 that we need to treat. The bone quality was not very good, and in order to get good primary stability, under drilling was required. In order to be able to choose from various drills, you need to use one cast drill kit. The wide implant placement drills range from 2.8 to 3.1, 3.3, 3.6, and 3.8, and you can choose the drill that you want. If you use one cast kit after tissue punch without initial drill, I used one cast drill 3.6 by 7 millimeter. The drill speed was 50 RPM. After tissue punch, one cast drill was used. A 5.5 by 7 millimeter implant was placed. The maximum size of implant that you can place with one guide is 5.5 millimeter. The instruction says 5 millimeter, but the diameter of guide hole is 5.8 millimeter, so you can place up to 5.5. Not many people are aware of the 5.5 millimeter implant. The thread of 5.5 millimeter implant, the thread is much better in getting primary stability. And at times I use it. The implant was placed and this was during healing. It was a flapless surgery. If you know the bone quality and if there's sufficient soft tissue and keratinized tissue, in order to maximize the effectiveness of guided surgery, you need to proceed flapless. Third case, I've used 1485 kit to place short implants in the mandible. 1485 kit was first developed for this purpose. In the lower, the distance to the inferior alveolar nerve is shorter, but the bone quality is better. Therefore, 1485 kit is better because it has a better drill efficiency. As shown, soft tissue amount was sufficient, however, the level of mouth opening was insufficient. In order to secure space for one guide surgery, vertical space was measured. The distance to the inferior alveolar nerve is 7 mm, but the condition for implant placement was quite tricky. I made a treatment plan with Implant Studio. I had about 1.5 mm of a safe distance. In this case, I needed 1485 kit with round tip to protect the safe distance rather than a one guide drill with a wide dimension. I've checked the accuracy of guide and used 3 drills to place the implant. First, I used 2.2 mm twisted drill. After that, I used a pilot drill, and then 5x5 1485 drill is used for implant placement. The implant used here is 5x5 mm BA surface implant. The reason why I chose BA surface is because it's great surface and it's insured. Soy implant is not insured as of yet, therefore BA surface was used. There was only about 1.5 to 2 mm up to the inferior alveolar nerve. After osseointegration occurred, scanning was done. One-step designer was used. One fit design and zirconia prosthesis were fabricated at the same time. One piece, which is a CAD-CAM abutment, was connected. ER-type prosthesis was set. After surgery up to the final prosthesis delivery, it took about 2 months, 3 weeks. This is after a year. You can see that the cortical bone has stabilized. Last case. I've used 1485 to place a short implant in the upper. Number 26 was problematic, therefore we had plans to place 2 implants within the sinus. There was a significant haziness, so much so that sinusitis was suspected. In this case, a sinus lift can be very dangerous. After measuring the amount of residual bone, I decided to place the short implant here. Appropriate design was made using Implant Studio. Guide was fabricated. Flapless surgery was done. 1485 kit was used. I didn't want to touch the sinus area, therefore, in order to place the 5x4 mm implant, drilling was done. Finally, I used a 5x5 mm 1485 drill. After punch out, a 2.2 by 4 mm twisted drill was used. A pilot drill 4 mm was used. Finally, 5x5 1485 drill was used. And a 5x5 implant, 2 of them were placed. Soy implants were placed. In a flapless manner, 2 implants were placed. If you look at the date, it's September 14th, 2022. This is when healing abutments were connected. Sinus membrane was not perforated. You can see that it's very close and implants were placed nicely. If the implant surface is soy surface, I check the patient after a month or a month and a half. I measure ISQ value. If it is over 70, I move on to the next prosthodontic phase. I did not touch the sinus, therefore, healing is done nicely without major problem. Next, I want to talk about my history. In order to come up with a certain procedure or concept, you have to review various journals and review them in an objective manner before choosing your procedure. Fortunately for me, based on my 21 years of clinical experience, I was able to summarize the various data. I was fortunate enough to get somewhat result that is compatible with other reviews. So I decided to look at the statistics of my clinical experience. Osstem defines a short implant as 6 millimeter, but I think a short implant in my clinical practice is between 5 and 7 millimeters. I first placed a short implant in 2010, so it's been about 10 years. I placed the 617 short implants and I made statistics out of it. The number of implants that failed due to various reasons, including failure of osseointegration, were 6. In most cases, stable results were achieved. 542 implants were 7 millimeter and 75 were below 6 millimeters. In my clinical practice, a 7 millimeter implant cannot be regarded as a short implant. It's just something that I use routinely in a standard manner. Overall, there's a very high success rate because out of 670 or over 600 implants, only 6 failed. It shows about 1% of failure rate. There were no specific length or surface that led to failure. Soy, CA, the diameter and length were 5 millimeter, 7 millimeter, and only 6 implants failed. If you look at the upper and lower, you might assume that more implants may have been placed in the lower, but 264 implants were placed in the upper. Under Osstem's definition of short implant, below 6 millimeter, the number of short implants were 75, and out of these implants, I divided single implants and splinted implants. 29 of them were single implants and splinted implants were 46, but I do not believe that splinted implants lead to higher success. The failure rate itself was very low and stable results were achieved. Now let's look at the types of implants and surfaces used since 2010. Since then, I've used TS3. I've used to use it as a surface, but I no longer use it. I use BA surface, and currently I use a soy surface a lot. I'm transitioning to soy surface. The most number of implants placed was BA surface from Osstem. The number of soy surface implants are increasing. The KS implant, which was recently released, have all kinds of surface. And the number of KS implant is on the increase. If you look at my clinical experience, over the past 10 years, out of 617 implants, only 6 implants failed. Yes, my clinical experience may be different with other people's experience, but my conclusion that I came to is as follows. Short implant provides predictable and promising long-term outcomes. That's based on my experience, and I understand that other people's perspectives may differ. Many people, when they talk about short implants, they say that short implants can achieve predictable and promising long-term outcomes so long as the right cases are chosen with precaution. However, in my case, such premise is no longer necessary. I think short implants show credible results. I really love short implants. I was given a short period of time, but I hope I was able to give you a good idea as to how much a short implant has contributed to my clinical practice. I would like to thank Osstem for giving me opportunity to speak. This is a topic that a lot of people are interested in. Thank you for the wonderful lecture. And thank you for sharing the long-term data with us. You've really shown that the success rate of short implants are similar to that of regular length implants. I think in that sense, it's very meaningful. Thank you for the wonderful lecture. In Osstem Implant, there is a digital dental technician contest for lab technicians, which will be held from November 10th to November 6th. So for 4 weeks, the contest is held in dental site. Come to the dental site and look at the presentations made by the lab technicians in the preliminary rounds and choose the right lab technician for us. Among those who participated in the vote, 1,000 people will be given Starbucks coffee coupon. I look forward to your keen interest. In November 19th, 2022, the main round of Digital Dental Technician Contest will be held. The total amount of winnings is 200 million won, and this is to uncover the best lab technician in Korea. I look forward to your interest. Dr. Kim Gi-sung, let's go back to the questions we were not able to answer previously. I look forward to your excellent answers to these questions. We've entertained up to the question raised by Kim's. Let's look at question raised by TS. Considering the unfavorable crown-root ratio when you choose the prosthodontic material, is the material that you prefer gold, zirconia, or PFM? I use all materials. If insurance needs to kick in, you cannot use zirconia. I use PFM and do metal occlusion. My favorite is zirconia because it's really popular. The crown size. Because of crown size, gold crown, it's not easy. I mostly use zirconia. You prefer zirconia. In patients that require insurance, I use PFM and do metal occlusion. Thank you for the wonderful answer. Doremi, very interesting lecture. Beautiful life. If the vertical residual bone is so insufficient where it requires use of short implant, which do you prefer, tissue level implant or bone level implant? If you use the same length. On top of my mind, in terms of joint stability, tissue level implant seems good, but based on my long-term data, bone level implant is more favorable because there is more possibility of new bone growth. Like platform switching, connection is in the inside, so I think that's more favorable. In the past, at times, the bone interfered, but because there's platform switching inside, you don't need to worry about that. So you prefer bone level implant. OHS, when you choose a short implant, was there a case where it was difficult to place the short implant? Yes. Even if you use short implant, if the distance with the inferior alveolar nerve is too close, at times it can be very confounding. I have asked help to Dr. Cho Young-suk, who is a wonderful surgeon, a couple of times because he has placed 5x4 implants wonderfully, but beyond that, I refer the patient to another dentist. Coffee beggar. This person is in the United States. I'm a Hyosin user. I am watching the live program. I love short implants. The platform surface, the bevel, if it is smooth surface instead of edged surface, won't it be more favorable for implantitis? I agree. If you're concerned about implantitis, smooth surface is better, but if you want new bone growth, I think edged surface is better. Understood? Dent 8789, I love your lecture. The coffee beggar. If there's implantitis and if there's a need for re-implant placement, won't it be better in that sense to place the short implants? If you place longer one, more bone resorption would occur. I agree, but Dr. Cho Young-suk likes 5x5 implants really much, but in my case, if the bone allows it, I think 7mm implants are better. If you consider implant explantation, short implants are good, but I don't favor 5 by 6 millimeter implant for all cases. If there is sufficient bone, I think 7 or 8.5 millimeter would be good. I do not just go for 5 by 6 millimeter implant no matter the situation. Good dentist, if you place a short implant, it means that crown length will be elongated in terms of long-term results. I don't think prognosis will be good. Do you place the short implants regardless of crown length? Yes. I do not believe in vertical bone augmentation. If you do vertical augmentation just because crown to implant ratio, it will take long time, and in my clinical practice, the results were better when I chose the short implants. If you consider time, cost, and all the other factors, placing short implants could be a good option. In terms of short implant, the primary stability will be very important. How many newtons should I achieve at least? How many newtons upon implant placement? This is very important. Short implants are normally placed in unfavorable conditions, and it is very important to get primary stability to get good prognosis. To drill short implant, many people hesitate and the drill hole can become too big. Primary stability may not be achieved. It may rotate on its own position. That's why I think guided surgery is important. You need to choose the accurate size, and if you use the guide here, you can get very good results. I think over 30 or 40 newtons of primary stability should be gained. You need 30 or more. Red cherry 1 in the upper posterior area. Will short implants advantages replace a sinus augmentation? I think a short implant can replace a sinus augmentation in sense. These days, a lot of sinus lift is done. If possible, if sinus is clean, I use 5 by 8.5 as I do sinus lift. But if there's a lesion or inflammation within the sinus, I prefer 5 by 6 millimeters. Yeonji Shi. In the upper posterior area, if you place a short implant, the crown will become long clinical crown, so crown to root ratio will become very unfavorable. Clinically speaking, for long-term prognosis, so what ratio should I stick by? If you look at Dr. Cho Young-seok's case, despite there being sufficient bone, he chose a short implant and the ratio is 1:4. He intentionally did that to prove the efficiency of short implants. I think 1:3, it's okay. If you look at the question, these days, the surface, they're not becoming the same. I disagree on this. As you use soy, you'll notice the difference. SA, SLA surface, they're similar, but with the introduction of soy, there are stark differences. Therefore, I think I disagree. If you look at this question, it asks, so which do you prefer, taper type or cylindrical type? I prefer TS3 taper type because it has better primary stability. All is well. If the cortical bone is thick in the lower, if you place wide implant, excessive torque can occur and implant may not be placed easily. In the case of short implant, you have to use wide implants. Are there difficulties in placing these implants? Are there any osseointegration issues if there are thick cortical bone? Yes, there are these problems. The distance to the inferior alveolar nerve is too close and you need to do sufficient drilling, but it's difficult to do so because it's cortical bone. Because of this, I use guided surgery To place a 5 by 6 millimeter implant, there's a 5 by 5.5 drill as well as 5.0 drill for hard bones. In this case, you can do osteotomy easily, and if you use a guided surgery with vertical stop, even if the cortical bone is really hard, you can get good primary stability. I recommend guided surgery. If cortical bone is thick, there can be issues with osseointegration. In order for osseointegration to occur well, you need to have a woven bone and there needs to be vessels, vascularization. In the case of cortical bone, will there be issues with osseointegration? It can be unfavorable. If there's little woven bone, you need to use better surface and you need to wait longer. More cancellous bone leads to better osseointegration. There is more cortical bone in the lower posterior area, Lee 74 NEN. What is the crown ratio when you place the short implants? 1 to 3. Is there a difference in how short implants are placed in the upper and lower? I think you need to place short implants deeper to overcome the disadvantages. Do you use the countersinking drill in the alveolar crest? I think it's about 1 to 3. I do not use countersinking drill. If you look at the guide kit, there's flattening drill. I just use that to flatten the bone. In the posterior area, rather than sharp bone, it's more flat. So in sharp areas, I do use flattening drill to flatten the bone a bit. Coffee beggar. This person is high-osen user. In the case of short implant, when you measure ISQ value, it tends to be lower. How much ISQ value compensation is required? When you measure ISQ of short implants, can you do this? Yes. When short implant was first introduced, because of the length of smart peg, ISQ values came out as 30. To overcome this issue, smart peg was improved. The new numbers are coming out. If ISQ value comes out as 30, although it should be more like 80, it's an issue with smart peg. If you have good primary stability and if the implant placement depth is good, I do not believe that just because it's short implant, the ISQ value falls lower. Based on our clinical experience, if it's over 70, I regard it as fine, even if you use short implants. Do you frequently see over 70? In most cases, I see ISQ values of 80s rather than 70s. After 6 months, if I unscrew because of an issue, the ISQ value is over 90. In the past, the ISQ values that I saw were 70s, but now I see ISQ values in 80s and 90s. The manufacturer says if the ISQ value is over 65, it's success, but I think there are a little bit of gray area here, so I think personally it should be 70. I use ISQ value of 70 to start working on the prosthodontic phase. These days, it needs to be at least 70 instead of 65. ID Yongyong. If you place 6mm implant, at times ISQ value cannot be measured. How can you check the level of osseointegration? This is the issue with smart peg. As of late, if you look at the smart peg, there are those designated for 6mm implant. The number of smart peg in the past, number 6 was used. After that, number 47 was used, and there was a switch in numbers once again. If you use a TS ISQ Smart Peg, you'll be able to get the correct ISQ value. What if you use the old Smart Peg but cut off the bottom bit? You get similar results? Yes. I don't think the manufacturer will like it. Smart Peg originally is for one-time use, but I've never seen anyone who just use it once. Yes, me too. You sterilize it. If you use plasma sterilizer, you'll be able to use it without experiencing any changes. You need to make sure that the temperature does not go up too much. You should not use autoclave. It rusts. IW, so you don't need to worry about crown to root ratio. Yes, that is in the thought of Dr. Kim Gi-sung. Lee 74NEN. I want to learn about components that to measure the amount of mouth opening to determine whether one guide can be fabricated. In doing guide surgery, a problem with it is that even though guide has been fabricated due to lack of mouth opening, it cannot be used. In this case, although a lot of investment has been made, you will not be able to use the one guide. To rectify the situation, Osstem has come up with a new product. It's not released yet. The length is being standardized and adjustments are being currently made. So you've tested the pilot product, yes. So you need to wait just a little bit to get your hands on the new product. Coffee Beggar, viewer from America, I appreciate your keen interest. I hope extra short line is introduced in Hyosyn ET3 lineup. This is something that we need to deliver to the CEO. LW? IW? I'm not sure. What do you think is the biggest cause of marginal bone loss in the initial phases of implant placement, and how can I prevent it? Early marginal bone loss. I think the biggest cause is related to placement depths. If you place it too shallow, bone loss can occur. Another potential cause is even if you have placed it sufficiently deep, if the healing abutment is too fat, it can hit the cortical bone, leading to mobility and bone loss. I think these are two biggest causes of bone loss. In terms of marginal bone loss, in November 19th, we're going to have Osstem meeting Seoul. There's going to be a symposium on marginal bone loss. If you come and listen, I'm sure you'll be able to gain a lot of insight. Please come to Osstem Seoul's Magok office and learn more about this topic. You'll be able to gain good knowledge here. Next, Lee 74 and EN. In patients with back conditions such as with a strong masticatory muscle or bruxism, does it affect the survival rate of short implant? Will it be okay? When I made the statistics, I did not exclude the patients with such conditions. Yes, it does have negative impact, but so long as the implant connection is stable, I do regular retightening. If you have done that, no major issues may result. I personally think you need to be aware if the patient has a very pronounced masticatory muscle. TS, wow, your data is better than SCI review. I think you've reviewed about 671 implants placed, and this person was really impressed. Happy day. These days, people tend to place implants deeper if you use one guide kit. How do you set the height relations between the alveolar crest and implanted top area? I tend to place implants slightly deeper. In the past, people said you need to place it 0.5 millimeter or 1 millimeter deeper. I believe you need to place at least 1 millimeter or 1.5 to 2 millimeter deeper. Are you talking about normal length implant? Yes, but with short implants, it's difficult to meet that requirement. I at times place 5 by 5, 5 by 6. If the implant top needs to be perfectly aligned with the bone level, in that case, I would place 5 by 5 and I would hope for new bone formation along the bevel. If I can go in by 0.5 millimeters more, then I would place 5 by 6 millimeter implant. Understood. TS. If short implant fails, how do you proceed with treatment? Upon short implant failure, how do you respond to it? I wait and attempt a short implant again. In the case of upper, if you place short implant, it means that you have not invaded the sinus. Therefore, I wait. I've normally placed a short implant in cases where I had to remove implants. I personally do not prefer GBR. Juan, you have accumulated quite significant amount of data. Lee74NEN. In the past, short implant was mostly known by Bicon. What is the difference between the implant you use and Bicon, and is there any difference in terms of survival period and cases that can be applied? In the past, you think of Bicon implant when you talk about short implants. Both Bicon and the implant that I use are internal type and share the same advantages. They have the same concept. And you can get similar results with that. Shin 8234, if the crown to root ratio increases in order to reduce stress, I think you'd need to pay more attention to occlusion. Yes. First, in terms of axial load, implant needs to be placed accurately. Cusp angle needs to be reduced and interference must be minimized. Occlusal table needs to be reduced, or mesiodistally it can be reduced. These principles I stick by too. The biggest difference is that after 1 year, I do retightening, and I do retightening every 2 to 3 years to prevent mechanical failure. Rather than group function, it should be cuspid protective occlusion, especially if there's issues with the anterior area. Yes, you need to minimize interference. I think the accumulated cases can be utilized. They're excellent data. In the case of upper, if you do not do sinus lift and place a short implant, do you think that is better option? Yes, you have already mentioned this. In general, Dr. Kim, I think you have mentioned that you'd avoid it if possible. When there is implantitis around the short implant, I think there's higher possibility of failure compared with long implant. In doing case selection, do you consider this factor? Yes, you're definitely right. If there's peri-implantitis when you use a short implant, because the amount of osseointegration is reduced, there can be higher possibility of failure. The reason why it wasn't that frequent in my case was because I tended to place a short implants deeper, and that led to fewer cases of implantitis. If there's implantitis compared with long implant, it can be unfavorable, but in my clinical practice, such phenomena was not observed frequently. OSS, good. Thank you for the wonderful lecture. In the case of uppermost distal tooth, single case, I am wondering about the stability of short implant. Is it okay if I use short implant in the uppermost distal tooth? Most of my cases involve the upper posterior most distal tooth. Can you share images of 6 failed cases? What is the cause of the failure? ID, awesome. I want to see the images of the failed cases. Did you bring them? I did not bring them today. So Dr. Kim Ki-sung of Namsang Dental Clinic will reach out to you separately. I think the failed cases were related to sinus. Last but not least, Pretty Sky, thank you for the wonderful lecture. I'm learning so much about short implants. I think this is the last. A lot of people have made comments and questions on short implants, and it really portrays the amount of interest that people show on short implants. Thank you for providing a wonderful lecture. I'm sure you put in a lot of effort into it. I think the viewers got a lot of meaningful tip. I'd like to extend my sincerest gratitude to those who have participated in the chat. Now we will choose the best question for today's Prosthodontics on Friday Live. The person chosen as the best question will receive 3 Starbucks coffee coupons. Dr. Kim, can you choose the best question? I want to give it to a coffee beggar, but I think this person is in overseas. I don't think the US Starbucks receives such coupons. I don't think it's accepted. I want to give it to Hatgui 12. I'm not sure whether it reads accurately. HATGUI 12. This person raised question early on. We wish we could send it over to you, coffee beggar. If you can use it, please inform us. Today, the lucky winner is Hatgui 12. I think it's Hat Guy. It's confusing. Congratulations, Hat Guy. Coupons will be sent on Tuesday to those who have won the lucky draw. At times, people are unable to receive coupons because they have not agreed to marketing on dental site. Please agree to marketing in dental site and get your winnings. Please don't feel too let down for not being selected as best question. The chat event carries on to the next lecture, so I look forward to your keen interest. Dr. Kim Ki-sung, a lot of people have asked questions and have listened in intently. Could you give a word of advice to your peers who are studying up until late? This is a repeat, but short implant is used in unfavorable conditions. There's no reason to use short implants where there's ample amount of bone. It doesn't matter if it is mandible or the maxilla. And it's not easy to get primary stability. Placing it appropriately is also not easy. When you use guide surgery, we can place implants without touching important anatomical structures. So in order to be able to utilize short implants accurately and well, regardless of the company, you need to use guides. I think this is imperative. Because primary stability is utmost important, you need to use guide. These days, the trend is to use digital dentistry, and a lot of people emphasize use of guides. In that sense, I recommend the viewers to use guide, especially when you use short implants for primary stability. It is strongly recommended to use the guide. Thank you. I'd like to thank you once again for coming to Prosthodontics on Friday despite your busy schedule. Thank you for inviting me. It's our pleasure. Dear viewers of Prosthodontics on Friday, I'm sure today's Prosthodontics on Friday lecture was very meaningful. We were able to get to many meaningful clinical tips in terms of using short implants. The questions that were unanswered, or if you want to get information on Dr. Kim Ki-sung's field cases, if you make requests, we will provide replies and address your questions. In the next lecture, Dr. Lee Soo-young of Obok Mansek Dental Clinic is going to talk about the latest trends in one-day zirconia restorations. Thank you for staying up with us until late.